Good evening, everybody. I'm Dr. Matt Rudolpher, Chair of the Washington Psychiatric Society Continuing Medical Education Committee, and it's my pleasure to welcome you to the start of a new season of our second Wednesday of the month CME webinar series. Tonight, we have the opportunity to revisit and build upon one of the highlights of the year so far, namely the poster competition for trainees that proved incredibly popular at last spring's WPS Presidential Symposium and Gala. We're delighted to welcome two of the 2025 poster competition winners, one in the hands-on clinical or basic research category, and the other taking the prize in the literature review research category. Here to present a fuller picture of their work than can fit on a poster. We'll have time for a few questions after each presentation. Please enter your questions into the chat box at any time. Incidentally, we are planning a third edition of the poster competition for trainees at every level in conjunction with next spring's Presidential Symposium and Gala, so stay tuned for further details later this fall. Now, to introduce our first presenter, I'm pleased to welcome a WPS CME committee superstar, Dr. Colleen Blanchfield. Take it away, Colleen.
Take it away. Good evening, everyone. Our first presenter is Dr. Noonj Kim. Dr. Kim is a captain of the United States Air Force. He's a resident in a dual program of internal medicine and psychiatry, which is very close to my heart. He works at Walter Reed National Military Medical Center, and while completing his medical school at the Uniformed Services University, he investigated the imposter phenomenon in medical students. He hopes to contribute to creating confident, capable physicians, officers to be leaders in the armed forces. We are so happy to have you, Dr. Kim.
Thank you very much for the introduction, ma'am. It truly is a pleasure to be with you all today. And so I can get started and share my screen in a second here. Okay, so as we mentioned, so I'm currently a resident at the Internal Medicine Psychiatry program, Walter Reed. This study was derived from a thematic analysis of a previous study that my team completed, which actually I did present at the previous year's WPS poster competition as well. That study entailed a semi-structured interview exploring if and why the components of the onboarding orientation curriculum influenced the med students' experience with imposter phenomenon, or sometimes referred to as imposter syndrome. And some of the themes we found included building relationships with classmates and upperclassmen, preconceived expectations, and what it means to be a military officer and medical student, and reevaluation of the merit, which seemed to be effective when comparing the accomplishments with other students. And these themes essentially led to the formation of a workshop that targeted this peer-to-peer and near-to-peer small group discussion, normalizing imposter phenomenon. And this near-to-peer interaction I'm referring to is where the different level of trainees teach each other. So like MS2s teaching MS1s or vice versa. So I have nothing to disclose. So the purpose of the study was to investigate how a workshop leveraging situated learning principles that is facilitated by MS2s. Does it say? Okay. That canceled my presentation when I started my video. Sorry about that. Okay, so the purpose of the study was to investigate how that workshop leveraging situated learning principles facilitated by MS2s and that near-to-peer and peer-to-peer setting may affect that sense of IP for onboarding MS1s and MS2s. And these workshops objectives were stated at the beginning of the workshop, including identifying at least two reasons why individuals experience IP, identifying at least two reasons of IP of others in a group setting, and developing at least two strategies to mitigate IP within that individual, and two strategies to mitigate IP for other group members. So imposter phenomenon briefly, so it was defined by Dr. Pauline Clance as an experience where an individual's belief in their success was due to chance, luck, and not associated with the massive their skill sets. And really in the past 2 decades or so, the literature has ramped up their investigation of IP and like exploring the correlations between IP and other biopsychosocial factors, including stress, low self-esteem, race, self-doubt. And when the students begin to question the merit of their qualifications and skill sets, it has been found that this performance and potential contributions to the learning environment can be stifled, and as a result, their professional development. So the study that the third bullet point on this slide refers to is actually based on my previous initial study, and the themes that were derived from the study can be summed up to essentially how applying situated learning theory can reduce feelings of IP. So this theory essentially, in this study's context, means by having direct interactions with their peers and their more experienced peers, the MS1s would be able to absorb the norms, values, and practices of the military med school community. And the methods, so this was a 60-minute workshop that was held during the orientation week at the U.S. Uniformed Services University. So as a USS, we have what we call learning pods or fire team. And a fire team consists of students with diverse backgrounds and completes different challenges, assignments, whether that's in medicine or military field practicum together throughout the 4 years. And the groups are randomly assigned by the Office of Student Affairs. And so for the workshop, one MS2 fire team was paired with a MS1 fire team. So we have a total of 8 students per small group discussion with no faculty present. And one MS2 from each fire team volunteered and received training to be moderators, and the participation was voluntary. And all MS1 and MS2 participants completed pre- and post-workshop surveys, which included the Clance Imposter Phenomenon Scale, or CIPS, which was the primary measure of how frequently an individual experiences IP. And there's no a gold standard for like measuring IP, but CIPS is recognized and utilized in the literature for its moderate to high internal validity. And a CIPS survey is scored out of 100 points, 20 questions, each worth 5 points on a Likert scale. And so the higher the score, the more IP experience. And the survey also captured demographic data, as well as other general questions not related to the CIPS survey specifically. And so initially the workshop, so the group was broken in half at the initial part of the session. So 2 MS1s and 2 MS2s got together to discuss the following points for about 20 to 30 minutes. So the MS2 shared experiences with IP during pre-clerkship year, and the MS1s discussed their confidence and concerns about starting med school, and also shared strategies to mitigate IP for self and others' IP experiences. And then after that 20, 30 minutes, the group came back together, and the moderator led the discussion targeting the 4 objectives aforementioned in my previous slides, and the 2 small groups shared what they discussed. And then after that, they completed the post-workshop survey, and the t-test and cross-tabs calculations were run. And so for the results, total of 222 medical students completed the survey, so 130 MS1s and 92 MS2s. And this was well reflective of the overall demographic breakdown of the respective classes. So 71% of MS1s and 57% of MS2s had decreased CIPS score post-workshop with an average drop of 4.5 and 1.8 points. And both were significant p-values. And 20% of MS1s and 34% of MS2s had increased CIPS score post-workshop. And importantly, though, the changes in CIPS score, whether positive or negative, they were not specific to gender, ethnicity, prior military service, nor gap year between graduating from undergrad college and starting med school. So there was a significant decrease in MS1's belief that they were admitted to med school due to luck or chance rather than their skills. And this also had a significant p-value. And the graph on the left shows the pre-workshop SIP score for both classes. And the big takeaway from this graph is that more than 65% of MS1s and 53% of MS2s had frequent or intense IP. And the graph on the right shows changes in the SIP score post-workshop, which I went over the numbers a couple of seconds ago. And this table displays changes in the threshold of frequency of the IP experience. So again, a score of less than 41 out of 100 points on the SIPS survey represented having few IP experience, and 41 to 60 points as moderate, 61 to 80 as frequent, and 81 or greater than 81 out of 100 points as intense IP experience. So the interesting thing, so despite 71% of MS1s and 57% of MS2s with decrease in the absolute SIP score that I shared in the previous slide, there were only 25 and 20% of subjects with the decrease in one or more threshold. And so now there are limitations to this study that may question the interpretation of the changes of the SIP score, which I will go over in the next couple of slides. And on the post-workshop survey, there was an open-ended question. Which part of the training did you find most helpful? And it revealed that students appreciated the open and safe peer-to-peer discussions as it enabled reflection and normalization of IP. Also shared best practices and strategies related to reducing IP, and promoted that a sense of belonging with the fellow medical students. As one med student noted, talking to each other and understanding we all share similar feelings make me realize it's normal and that it's important to talk about it and explain why we feel that way. And essentially the root of these discussions was to normalize the stigma around imposter syndrome, which the open-ended feedback reflected the success of the normalization of the stigma. So some limitations to consider. So the non-response bias and social desirability bias may be present given the existing perception of the stigma for some individuals surrounding IP. And secondly, the post-workshop survey may have captured the immediate effects that had not yet translated into significant threshold changes in IP. It is possible that continued application of workshop strategies over time could lead to more substantial shifts in IP categories. And the long-term follow-up studies would be beneficial to assess the durability of the workshop's effects and to determine if additional interventions or support may be necessary to maintain improvements in IP experiences over time. And thirdly, this is a study of association and not causation. So in conclusion, discussing IP in near-peer and peer-to-peer setting and fireteam structure fosters this safe integration to the learner's new community through the normalization of IP and decreasing that sense of IP. And through situated learning theory, subjects felt significantly more prepared to identify the signs of IP and develop strategies to mitigate IP. And future research requires evaluation of students whose IP score increased post the workshop, and indicating that they experienced more IP. And these are my references, and I have my slide for any questions at this time.
Sorry, that was very good. Thank you, Dr. Kim. We will take questions.
Sure.
What are your thoughts about why the students experienced an increase in the SIP scores?
Right. So, the initial study that I referenced earlier, so one of the themes that came out of one of the more popular themes that came out of that the thematic analysis was that, students comparing their merit against their peers. And so during this, small group discussion, I'm sure, the MS2 class, talking about their experience during their pre-clerkship phase, as well as their MS1 colleagues talking about, some of their, prior accomplishments or their background, essentially. during that discussion of sharing their, more experienced backgrounds compared to others, that was a common reason why the learners felt experienced more IP. Excuse me.
Quite all right.
I have a question.
Yep.
You have to go through the chat room.
I was forced to use my iPad mini, and it doesn't have room for
Okay,
the chat room.
excuses, fine, fine.
If I may, to add on to my previous, is it okay, Dr. Rudorfer, if I add one
Please.
more comment to my previous question?
Of course.
So even like as a med student at this military med school, like within 1 year of going through med school, like we get a lot of exposure to other like our military staff and even upperclassmen who themselves have learned quite a bit about the military system. And so one of the discussion topics that would come up during this small group discussion is like what should the MS1s expect in terms of what does it really mean to be a military physician, and like what are some of the like military qualifications or additional training that we have to go through. And so sometimes the military, the unexpected realization of some of the points that we have to hit as a military officer, that sometimes they catch them off guard too. And so, and like military physicians, there are 3 or 4 different tracks that we can pursue, and learning about those tracks too, it gets more overwhelming to some learners. Just knowing like there's just so many, not only as a physician to grow, but there's just so many other steps to partaking in order to grow as a military officer too. So that was another contributor to increasing IP.
Yeah, in fact, I noticed that history of past military experience you found did not affect the outcome.
Could you repeat that again, sir?
I said on one of your slides, you said that the history of past military experience did not seem to make a difference in terms of the outcome. I have that
Correct.
right?
That's correct.
Because I'm thinking that from what you were just describing, it does sound like the situation is more complicated, say, than it would be in a civilian medical school, because the MS1 folks are headed towards identification ultimately as a physician, but also as a military officer. So
Right.
Do you have any sense of how these kinds of findings would compare in a typical civilian medical school?
Right. And the idea of like essentially what the study that I investigated, what was unique about it was we like by default, we have like these learners developing 2 identities, right? As a physician
Right.
and as a military officer. And so of course, like this is not unique to military, individuals, right? Like, there we have mothers who are developing their identity to be a mother or father and undergoing med school, things like that. And so like in that sense, I think the results that we found from this workshop, the fact that despite their military background, that did not seem to have like a correlation with how their CIP score increased or decreased after the post workshop, right? So that was quite surprising to me, because that means that whatever conversations that these small groups had, like it really didn't like impact whatever background that they were coming from, or whatever demographics that they were exposed to prior and are coming into. And so so does that answer your question, sir?
Yes. Yeah, thanks.
We have another question here. Could you talk more? Hang on. Could you talk more about the 25% decrease in one or more threshold, and how you think this could be investigated? And I'm just going to follow that up, is that those people who had a increase in their CIP scores, were they given any follow-up?
So to answer the latter question, so we did not capture follow-up for these folks. That was actually another research question that my team considered looking into as well. But yes, so I can't, provide much more detail than that. So for the first part of the question about the 25% whose score decreased by one or more threshold. So was the question essentially like, how do we further interpret that data?
Yeah, I'm sorry. I didn't write it very well, but essentially you talked about that you didn't show such a robust decrease in threshold as was shown in the other SIPS scores, if I'm understanding it correctly.
So here, let me see if I can pull the slide back up.
Yeah.
Here, I'm going to share my slide again. Let's see. So we're talking about this slide, is that right?
Yes. Yes.
Okay. Decrease by one more threshold and then no change. Okay.
Right, but you had a higher a better decrease in SIPS scores, but that wasn't the same as as decreasing by the threshold.
Oh, right. I see what your question. Okay. Yep. So this, that is one of one of the more disappointing limitations that my study team experienced because, and here's the thing, as I mentioned, the SIP score, although commonly used in literature, in terms of how to really interpret like the change, like essentially individuals moving from threshold to threshold, like we can't really, like, how do we know that, for instance, like a score of like a 42 out of 100, that would be considered a moderate IP experience. And like an individual can move threshold if, they literally drop only by 2 points, less than 41 score, right? That would place them on like few IP experiences. And so like, whereas you can have someone who did not jump a threshold, but they still had like a 20-point drop, right? And so so that is one of the larger like limitations of utilizing this tool. And yeah, which is quite unfortunate. And that being said, I was more interested, frankly, on the I didn't do a full like qualitative thematic analysis like I did with my initial arm of this study, but like I was more interested in truly like the open-ended, the free response, feedback from this session, and here I have that slide here about asking like what part of the training did you find most helpful, and so like there were like more than 100 of like free response feedback, and I was quite pleased, at least the goal of the workshop, for these learners, was to be able to essentially identify the signs of IP and how to mitigate them. And there was just overwhelming response of, these learners having just a lot more confidence in their ability to hit those objectives. And so, but yeah, so that is one of the limitations. And of course, the editor commented on that limitation as well. But yeah.
But that's really more a limitation of the tool than necessarily of your study.
Correct, because the pre-post workshop, we did the T-score like evaluation, and there were significant drops, per the statistical test, and so. But that being said, so like I guess then the data that I shared about the absolute changes in the absolute SIP score, that produced that significant data, but the changes in the threshold percentages, like, I can't, confidently state or statistically confidently state that, this was a significant changes in threshold findings, if that makes sense. Yeah.
I just don't want to talk out of turn here. Okay, we have one more question, Captain. Does the demographic data reveal any differences in the IP presence and response to the workshop due to gender or racial identity? This is being asked because she couldn't tell from the data shown, and this person is suspecting that there is a cultural variability.
Right. And so, with the Um, Give me a second. So with the t-test that we ran, so essentially doing the crosstabs calculation to try to pinpoint the different demographic factors, whether that's gender or ethnicity or even like prior military service. So the p-value was not significant, and so that's why that's how I came to this kind of statement about the changes in SIP score, whether that increased or decreased. It wasn't specifically correlated to like the gender, ethnicity, or the prior military service. Does
Okay.
that answer your question?
Yes, thank you. And thank you for reminding me that you had indicated that
Oh, no
in that
worries.
last arrow. Very nice presentation. Thank you.
All right. I think that has come to the end of our questions, and I want to thank Dr. Kim very much for this wonderful presentation.
Thank you. And please feel free to reach out to me for any further questions. But yeah, this project of all the projects I've worked on is one of my favorite ones, because just seeing those MS1s and expressing like how much of an impact this workshop had for them. That's what's this all about, right? And honestly, there's nothing more regretful than seeing a colleague falling behind when it could be avoided. Because of a systemic barrier.
Yes.
So
Yes.
I appreciate you all listening to my talk today.
Well, we appreciate your time and energy into this.
Safe travels on your way as well.
Colin, can I just ask one last question? And I want to thank you so much for this wonderful presentation. And I've got to tell you that I'm particularly interested in this domain because it sort of correlates with something that's going on in medical education broadly in terms of trying to ascertain qualities and traits that are predictors of success as physicians. And it's something that we don't have much, if any, data on whatsoever. And one of the things I'm curious about, and this goes a bit beyond the scope of what you're so nicely presenting to us, is this idea of the imposter phenomenon itself and its association with certain traits, most notably with introversion, and the idea of the well-suited notion of having us want to reduce that phenomenon for individuals in terms of their experience. But I'm curious if there's anything that you have gleaned on predictive value of some notion of imposter phenomenon being actually a positive predictor for performance.
So, thank you for that question. My study, we didn't specifically, look like run tests like calculations, trying to get those predictive scores. But but during my literature search, I know that, and as I mentioned, like a lot of studies been done recently about IP and other correlators, and I know like grit. I really wanted to add the grit scale and possibly have run even like possibly even like mixed methods between grit and the SIP score, as well as the qualitative responses. But I definitely, one that really recurred in my literature finding was individuals' resilience and grit. And there's a survey out there that for measuring grit that a lot of researchers utilize, but yeah, and I think other predictive kind of factors, looking at least my study population. Let's see. I guess, well, I can't say about, well, I guess I could. So like the fire teams that I mentioned earlier, like when the group of 4 learners are, because I didn't know this, that not a lot of med schools, in the civilian sector, have this like small group like learning pods like set up for the medical student classes. And because I have a sister in civilian med school too, and where some med schools are prone to like isolating students, quite a bit, especially in the clerkship year too, even worse during that time. And so like when the individuals who take advantage of these fire teams, because they're fire teams here at USIS, like not all individuals take advantage of them. In like the nice thing about the introverts, right, taking advantage of this fire team is that like because there's so many assignments, both military and non and like medical related, practicum activities that they go through. Like, I mean, and of course, like in theory, like when the med students apply to military school, like in theory, like they have a lot of leadership experience, right? But so even then, like those with like who are more introverted, like in this very safe small group, fire team, like when utilized correctly or effectively, like feeling like they can communicate with their, essentially their second family. I think for those individuals, they did gain quite a bit in terms of, being able to essentially be more vulnerable, with their classmates. And so with more activity, with more assignments and activities, and like students, by nature, med students, like, they vent to each other, right? Even residents, they vent about, their experience during residency. And so like through that, the normalization of discussing about, what's really contributing to their imposterism, I think, so essentially utilizing the fire teams was like a predictive, predictive factor, if you will, to see how well that individual reduced their sense of IP. And so like, yeah, I would highly, recommend, other programs out there, medical schools out there, residency programs out there to establish this, peer-to-peer, small groups like learning pods, to help reduce sense of IP.
I know that we have to move on, but as I listen to you talk about and use the word safe settings, I think about my own experience as a resident where they had a group of the residents and we were supposed to be in group therapy, and it was not a safe setting. So I think, that that's so interesting, Todd, that you're bringing this up about what's going on in medical education, because a year or two behind me, a student died by suicide. So, safe is an operative word, I think, as well, in terms of your fire teams.
Right. Yep.
I agree. I agree.
Apologies for that long-winded response. But
Okay, shall we go forward?
Good evening. I, Anne Marie Dietrich, have the privilege of introducing Dr. Keti Kutidze, who is a PGY2 psychiatry resident at Tower Health Phoenixville Hospital in Phoenixville, Pennsylvania. She earned her medical degree from David Vildiani Medical University in Tbilisi, Georgia. But prior to beginning her residency, Dr. Kutidze taught medical sciences at the University of Georgia. Her clinical interests include at-risk psychosis states and the psychopharmacology of psychotic disorders. Dr. Kutidze is particularly interested in the emerging role of inflammation in schizophrenia and the exploration of novel adjunctive treatment strategies. She has no relevant financial relationships to disclose. Dr. Kutidze, thank you for joining us.
Thank you for having me. It's a pleasure. So my name is Keti. I'll be talking today about inflammation and schizophrenia connection, as well as the evidence for the anti-inflammatory medications for the psychiatric benefit in psychotic conditions. So I have no financial or other conflicts to disclose. And this is the outline of the presentation. We'll talk about the history and pathophysiology of immunity and psychosis, and then we'll talk about some of the medications that have been tested, like aspirin, celecoxib, minocycline, statins, and antioxidants. And then in the end, we'll talk about the future directions in the research. So as introduction, the inflammation, we are constantly exposed to toxins, trauma, infections, and we have evolved this inflammatory response to help us fight pathogens, to repair damaged tissue and restore balance. But it is a double-edged sword in the whole body as well as in the brain. And while acute inflammation can help us in the brain, the chronic low-grade inflammation in the brain can alter neural circuits and affect mood, cognition, and behavior. And this is not a new idea of the 21st century. The psychiatrists have been speculating about this for years. And even though the brain once was thought as immune-privileged, isolated organ in the body, now it is more modern evidence shows that it's not, and it's still in the connection with the whole immune system. And just a little bit of history with like the milestones in the psychosis and immunity. So in 19th century, early 20th century, there was this idea that typhoid, fever, and malaria could cure psychosis. And then in 1927, Wagner and Jorag even won the Nobel Prize for inoculation of malaria in syphilitic psychosis with induction of high fever and basically the immune response helping to fight infection. There were cases described of post-influenza psychosis, highlighting the possible link with the infection and the psychiatric illness. Then sometime in 20th century, there was noted a link between the seasonality of birth and schizophrenia, with the winter-spring births being connected to the psychotic disorders. Lehman and Fassius, they described autoantibodies against the brain structures in the CSF of the patients with schizophrenia, posing questions, maybe it is autoimmune disorder. And then in 90s, there was this new line of research trying to see if in utero exposure to infections in mothers could somehow lead to the fetal psychotic disorders. And there was no association with this particular flu cases, but that basically started the research into maternal immune activation and the further chances of development of psychosis. And then even though this is, certain researchers and clinicians have been speculating and talking about fever, autoantibodies, maternal immune activation, all of this was largely observational and maybe even speculative. So let's now discuss some of the evidence that there are changes in the immune profile in patients with psychotic disorders. And so we'll look at the different components of the immune system and how they correlate with psychosis. So the first and very important part of the immune system are cytokines, and there is a very strong evidence that there are changes in the cytokine profile in patients with schizophrenia. There is an evidence that there are increased pro-inflammatory cytokines like IL-6, TNF-alpha, IL-1 beta, and these are mostly pro-inflammatory, and then there are decreased anti-inflammatory cytokines like IL-10, and that is especially pronounced in patients in acute relapses. There is very strong prospective evidence as well in Avon longitudinal study of parents and children. The cohort has a very robust data set, and they saw that elevated IL-6 in childhood correlated and doubled the risk of developing psychosis and depression by the age 18. And this there was a clear dose-response relationship between the levels of the IL-6 and the psychiatric disorders later. And that was even adjusted for sex, BMI, and early psychological difficulties. So this link was really strong, and the prospective evidence is there. And interestingly, even in the first episode psychosis, that's when IL-6 and other cytokines are elevated, and even in the prodromal phases. And then some of the studies show that with antipsychotic treatment, the levels of the interleukins sometimes normalize. And increased cytokines could be drivers of the pathophysiology, or they could be just secondary consequences. We don't have the answer, but there is some evidence with this prospective evidence that maybe this is one of the pathophysiological reasons for development of the illness. And the next question is, how do cytokines affect symptoms of the psychosis, and how do they present themselves? And one of the pathophysiological mechanisms is the neurotransmitters. So with the classical view, we have dopamine dysregulation, but we have now emerging views and we are interested in other neurotransmitters as well, and the NMDA receptor hypofunction and glutamate. And it was shown that pro-inflammatory cytokines, they affect the tryptophan and kynurenine pathway, and the kynurenic acid is our natural NMDA antagonist in the body. And by increasing kynurenic acid, there is disruption in glutamate and dopamine signaling as well. So that could be one of the pathways how cytokine levels can influence the psychotic process. The next part of the immunity we need to discuss is microglia. And there is also an evidence that there is increased activation of microglia in patients with schizophrenia. And there is a postmortem as well as imaging studies with PET. And interestingly, this also shows that microglia is excessively activated in patients at high risk for psychosis, even before the clinical symptoms show. And microglia is very important for synaptic pruning. So overactivation of the microglia can cause excessive loss of neurons and promote the development of psychosis. But it's not specific to psychotic illnesses. It's also observed in depression, bipolar, autism. So it may be transdiagnostic for multiple psychiatric diseases. And activation intensifies as illness progresses, but it's still a question, is this the driver or is it just a result of the illness? And for microglia, there is another important aspect we need to discuss, and that is the phenomenon of sensitization and kindling. So microglia has this ability to basically remember prior immune challenges, and early life insults like CNS infections or systemic infections in utero or in childhood can prime them into being hypersensitive in the future. And then later, like milder insults may cause exaggerated cytokine release and exaggerated inflammation. And that is basically called the immune memory of microglia. And it explains this link between the childhood CNS infections and increased schizophrenia risk in the future. And it also clinically ties into the stress vulnerability model of schizophrenia with early immune insult and then later stressors heightening the vulnerability for psychosis. Oxidative stress is very prominent in schizophrenia. And there are multiple meta-analyses showing that there is decreased antioxidant capacity in first episode psychosis and in relapses. And even though it is most likely to be the result of the illness itself and not the causal factor, it is still an interesting target for future therapeutic medications to at least mitigate the damage done by the oxidative stress. And we will discuss antioxidants, N-acetylcysteine, omega-3 fatty acids in the end of the presentation, but that could be one of the therapeutic targets for treatment. And then the last component I want to discuss here is T cells and B cells and the humoral immunity of the body. And there is evidence that T and B cells are increased. They are activated excessively during acute psychosis, and they also are very prominent in hippocampus, especially in patients with prominent negative symptoms. And the ratios of CD4, CD8 cells, as well as NK cells and activated T cells are also altered. It is very difficult to say for sure what's going on because many studies, they do not many studies also include patients with different BMIs, with different comorbidities and psychotropic medications that could alter this irrespective of the inflammation. But this is something that is going on, and it would be interesting to know what part is the lifestyle and the environment and what part is intrinsically psychotic inflammation changes in the body. So next question that arises after all this is inflammation in schizophrenia a state or a trait marker? So we can briefly discuss the difference between state and trait markers being stable features present regardless of symptom severity, and state markers being markers which fluctuate with acute illness, with relapse, with chronic illness, and they're particularly important in exacerbations or remissions. And there is evidence that inflammation often rises during acute psychosis and subsides in remission. So it looks like inflammation behaves more like a state marker for psychosis, with IL-1B, IL-6, TGF-beta all rise during acute psychosis. However, there are some stable markers which are present across the illness course and do not fluctuate and behave like trait markers as well, like IL-12, interferon gamma, etc. So it is more complicated than just the difference between these two. So to summarize how inflammation drives psychosis, we have multiple mechanisms, but one of them is definitely neurodegeneration, microglia causing the release of cytokines, oxidative stress. There is a degeneration and synaptic pruning, and all of that contributes to the gray matter loss and all of the symptoms and cognitive decline as well. As we discussed, with neurotransmitter disruption and kynurenic acid production, and as well as neurodevelopmental lens, where we mentioned that microglia gets primed with early life insults and then creates this environmental additional risk to genetic vulnerability in humans. So these are the medications which I will briefly discuss. On the left side are the medications I have in my presentation, and there are so many others which I could not include, but the studies are mostly very small. There are no robust RCTs for many of those medications, so hopefully in the future we'll be able to look up some of these medications with more evidence. So the first medication, which is the most obvious one to start with, is aspirin. And with aspirin, it is widely used for multiple reasons: fever reduction, pain relief, cardiovascular protection, it also decreases the inflammation, as we said, with COX-1 and COX-2 inhibition, as well as platelet aggregation. And by decreasing inflammation peripherally, if used in high enough doses, it will cross the blood-brain barrier and also decrease the inflammation there. So around 1,000 milligrams is the dose for aspirin to have a central nervous system effects. And that's why in the first study, Lan et al. In 2010, that was studied in the Netherlands. It was 3 months RCT. So they had 70 patients and they had our sparing group with their antipsychotic plus aspirin, and then just antipsychotic with placebo. They used 1,000 milligrams of aspirin, and the results were that it had medium side effect, mostly on the positive symptoms in the PANSS, and there were no significant effects on the negative or general symptoms. Most important part of the study was that they also stratified based on their immune profile. So they had a stratification based on their Th1, Th2 ratio of cells, and they found that the greatest effect size correlated with more disturbed immune profile of a person. So the effect was strongest in those with Th1, Th2 ratio that was low. And the difference was quite significant. So it created an idea that maybe some people have more inflammatory phenotype of the disease, and then in those people, the medications can be more effective than those who are less affected by the immune changes. Also important thing is that in this study, the exclusion criteria was that the diagnosis was no more than 5 years, because the idea was that because schizophrenia is at least partially neurodegenerative disease, after some time, interventions might not be as successful. So they mostly looked at people in the earlier stages of the disease after the diagnosis was already made. And this study was done, and then to replicate the effects, there were multiple other studies done, and the next one was done in 2019. It was Atari et al. This study was really underpowered. They had 3 groups, and each of the arms had 20 patients. And here the dosing of aspirin was also different from the Lan study. In this study, surprisingly, all their outcomes were improved, both positive and negative symptoms were improved, and also interestingly, no adverse effects were reported. Generally speaking, in other studies, non-psychiatric studies, at the dose of 1,000 and even like lower than that, there are many cases of adverse effects from aspirin, especially the GI bleeding, but Atari and Lan did not show any adverse effects, and maybe with the longer term treatment, more adverse effects would show up. But this study was really small. There was short duration. There was no biomarker certification, and the evidence from this particular study seems to be really weak. And then to finally put this debate to end, there was more like a larger study, RCT, done. It was called Wiser Studies. This was a very well-designed study, and they had two sub-studies in it. First was done on general schizophrenia sample. There was no selection of patients, and this was 1,000 milligrams a day of aspirin. And then the study two, interestingly, was done on patients with the inflammatory profile. So they selected patients with CRP more than 1 at baseline, and then they wanted to see if the inflammatory phenotype was more responsive to the treatment. But unfortunately, none of these studies showed any improvement on any PANSS scales. And in study two, aspirin did not even reduce CRP levels. So it absolutely failed to replicate the earlier positive findings. And we'll see it in other studies now in the future slides that smaller scale studies, older studies are showing some promise. Scientists get hopeful, and then the bigger study is done and it fails to replicate any findings of the prior studies. So that's the aspirin study. And then the next agent that was evaluated was celecoxib. And celecoxib was hailed as more safer alternative to aspirin and all other NSAIDs at first due to selective COX-2 inhibition and less risk of GI bleeding. But eventually, with the FDA black box warning, it fell out of favor. But due to the immune effects of celecoxib, it was still evaluated for add-on treatment. It has COX-2 inhibition in modulation as well as glutamatergic regulation properties. And so there were a couple of studies done for celecoxib. The first one was Mueller et al. In 2002, and this was even prior to aspirin studies. This was the first add-on anti-inflammatory study done that basically primed the future studies. And this was also 50 patients, double-blind RCT, and it was acute exacerbation patients. In this case, the antipsychotic was fixed. It was risperidone, and then celecoxib 400 milligrams was added. The dose was chosen absolutely empirically. There was no data why 400. We don't know if more or less can work, but the results were promising. Of course, both groups improved with antipsychotic, but celecoxib add-on group showed greater improvement in total PANSS as well as positive symptoms. There was even some data for negative and general domains. But that was basically this effects disappeared at the endpoint of the study when endpoints of both groups converged. So what the study showed is that this add-on of celecoxib accelerated early symptom reduction, but in the end, they all reached the same PANSS scores. But still, of course, accelerating the symptom reduction would be a great benefit. So this was a promising study, and other studies began to try to replicate these findings. The next one was Rappaport. And this study chose chronic patients with schizophrenia. So in Mueller, this was acute sample. This was a chronic stable cases of schizophrenia, and it absolutely failed to demonstrate any differences. The only caveat is that maybe there was a stage-specific effect. Again, early and acute stages more responsive to treatment than the chronic and more stable. But also, it has to be said that Rappaport chose patients who were not responsive to their antipsychotics as the cohort for the treatment. So maybe the selection bias could also explain why there were no effects in Rappaport studies. And then there were multiple other studies trying to finally replicate the first. In a Conazec study, there was some improvement with the primary outcomes, but no effects on the negative symptoms. And then again, there was a big study done, RCT, with more patients than in all the other prior smaller studies. And this was the first RCT to select patients on pro-inflammatory profiles. So they selected patients with higher levels of IL-6 and other interleukins, just like Weiser studies. And they also had a longer follow-up, like 4-month follow-up observationally. So this was a very promising study. Unfortunately, results are not published yet, but this could finally show us if there is any evidence to believe that celecoxib could have a benefit in the case of psychosis. There were no significant side effects noted in any of the studies before, but again, the follow-ups are so short, we don't know what happens with years of add-on treatment with these anti-inflammatory treatments. The next medication that was evaluated was minocycline. In addition to its antimicrobial properties, it has robust anti-inflammatory properties. It inhibits nitric oxide synthase. It shifts microglia from M1, which is pro-inflammatory, to anti-inflammatory state. It is anti-apoptotic. It's neuroprotective. And it even attenuates some of the NMDA antagonist-induced neurotoxicity. So this was very promising. It is also very lipophilic, so it crosses the blood-brain barrier easily. And a lot of studies were done. And in the early 2000s and 2010s, there were case reports and some open label studies and some very small RCTs from various countries. And there was a lot of hype. There was shown benefit for negative symptoms, especially, and cognition, which are some of the more difficult aspects to treat. So some trials showed that there were reduced pro-inflammatory cytokines as well, and the side effects were moderate at least. There was no effect on positive symptoms. And then based on this positive signals for such resistant symptoms such as cognition and negative symptoms, larger trial was done. It was called Benjamin trial in the UK. It was the largest RCT to date about the minocycline. And the follow-up was 12 months. So this was the longest follow-up they could do. It was about recent onset schizophrenia. And they measured clinical outcomes as well as inflammatory profile of the patients. And they found no clinical benefit or even a biomarker benefit. So even though in animal models, minocycline was known to decrease inflammatory profile, in the Benjamin trial, there was no biomarker benefit. So they concluded that it is not effective as an early adjunctive treatment. So that's the story of minocycline. And then we go to statins. These are so widely used lipid-lowering drugs, especially in population with psychiatric illnesses who are more prone to metabolic dysregulation. The scientists are really curious to see what if there is an add-on benefit, because in addition to its metabolic effects, it also has various effects on inflammation, oxidative stress, and it even might increase BDNF. So studies were done. Early RCTs again showed some evidence on positive and negative symptoms, but then there was done the largest trial, Somers, in 2020, and showed no significant efficacy. It has to be said, though, that statins differ by how lipophilic or hydrophilic they are. Some of them cross the blood-brain barrier more easily. So in this case, simvastatin is shown to cross it most easily, and was the statin that was studied the most and has more mixed evidence. Other statins usually show no effect. So simvastatin might show some benefit with both positive and negative symptoms. And then lastly, I want to talk about antioxidants. This is based on Cochrane review of multiple antioxidants. There were 22 RCTs with more than 2,000 participants. Unfortunately, most of the studies were of poor quality. They had short follow-up, they were underpowered, and the results were so heterogeneous that it was impossible to have a consistent evidence for or against. Safety-wise, most of these adjuncts were safe without side effects, and there were only 2 antioxidant treatments which might have some benefit and promise in psychotic disorders, and these were ginkgo biloba and N-acetylcysteine. With ginkgo biloba, the studies were still small, and they were overwhelmingly in Chinese inpatient populations, but there were some signals for short-term reduction in rating scales, especially positive symptoms. While with N-acetylcysteine, there was some evidence about the negative symptoms, but there was no signal for positive symptoms or functioning or other differences. Still, this evidence is not strong, but in Cochrane review, these two antioxidant treatments were standouts compared to the rest. So the key questions for the future that are here that we still need to answer. We still don't know if cytokines are cause or consequence. We still don't know how to predict onset, progression, or treatment response. Even though we know that these markers rise, they are not really powered to be used in a clinical setting daily. We need to learn, do these inflammatory processes underlie the cognitive decline and the brain volume loss? Also, could this early life adversity increase the risk of psychiatric illnesses via the immune mechanisms? Can we track microglial activation and track it with illness severity? If we control inflammation, can we improve psychosis outcomes? And also, can we stratify patients by immune phenotype to guide the personalized treatment? These are all the questions that still need to be answered. And future directions are, of course, novel interventions. There are multiple new drugs being studied, like methotrexate. There are monoclonal antibodies being studied, and microglia modulators, many medications. It is difficult to one of the limitations of this study is that we cannot see if they are independently effective in psychosis, because we cannot design a study where we do not give antipsychotic to acutely psychotic patients. So is this the synergism with antipsychotics? Which mechanism is responsible for what effect? We don't know. So this is also the question we need to answer. We need to know what is their long-term tolerability. 3 months of aspirin versus 10 years of daily aspirin in high doses. We need to be sure that these high doses are safe. And we need to determine if the inflammation is the causal factor or more a consequence of the disease. And yeah, also very important would be to focus on different stages of disease, prodrome versus first episode versus more chronic illness, and see if there are any changes there. So these are all the future directions. Unfortunately, there is no strong evidence for the anti-inflammatories we studied for now that there is a benefit of adding them to the daily practice, but there is definitely something going on here, and it's a very complex process. So hopefully in the future we'll have more information and we can alter our daily practice and incorporate some of these interventions. Thank you. These are my references.
Thank you so much, Dr. Kutidze. That was a tremendous presentation and a wonderful literature review. We have time for probably 1 or 2 questions before we say goodnight. Is there anyone that has something right now? Otherwise, I am wondering what your thoughts are. Let's see, I have one. Dr. Dunlap has commented about it being a very interesting review, which I will second. And she's asking exactly what I was wondering about is, did you find any information on use of GLP-1 medications?
Mm-hmm. And I asked because of the potential role in treating inflammation.
Mm-hmm.
Excellent presentation. Thank you.
Yes, thank you for this question. Definitely with GLP, there's a lot of signals with the inflammation and the effect on psychotic as well as depressive and substance use illnesses. The data is still mixed with the GLP, but the signals are really strong. And there's a lot of studies being done with the GLP, so hopefully we'll get larger RCTs that are directly with the inflammation. I don't have any specific studies in mind that look directly at the inflammatory profile and psychosis with GLP, but that would be a really interesting angle to explore.
If I could ask a question, you mentioned about stage specificity. If I understood your early slides, as early as childhood, increased inflammatory markers can be seen. So presumably by the time one is clinically ill, that might be present for 15 or 20 years, right? I mean, would you see any merit to trying anti-inflammatories in a young person, say with a high family history of schizophrenia?
So there is like a whole field of, exploring which medications could help with at-risk psychotic stages. One of the medications which showed promise was omega-3 fatty acids. The data was not very strong, but it showed some benefit. And it was unclear whether this was effect of establishing the psychiatric care early on and following up and the supportive psychotherapy, or was it the medication itself? But there were several studies showing that omega-3 supplementation at risk psychosis decreases the transition rate. But it's very difficult to assess because, first of all, what is at risk psychosis? There are so many types of that, and so many people just are lost to follow up and never even check. So there is selection bias of those people who do go to the clinics, as well as the transition rates measure. It's very difficult, but there is definitely data for omega-3 specifically. For all the rest, I think there was no evidence of benefit.
Okay, thank you.
Dr. Cox.
Yeah, thank you so much. What an excellent presentation. It was really, really wonderful. And one of the things I just, in listening to you, this notion of biomarker, it sort of resonates, back decades ago when the hypothalamic pituitary adrenal axis led promise to the idea of cortisol being a biomarker in this regard. And, and in that way, when you think about this, and the other comment that I would make is this was a robust conversation about inflammation in schizophrenia, but the reality is, but the reality is, I think now when we look at many of our conditions, we could substitute the word schizophrenia
Exactly.
the presentation with just about every one of our major mental illnesses. And when we look at the activity of so much of our treatments that are now considered standard of care, what they do, like ECT, what they do, right, is result in a diminution in inflammation eventually, right? And so it is an incredibly interesting domain, and has, I think, huge implications for, just like you're saying, diagnosis and stage, and it even sort of resonates back to Kraepelin's notion of distinction of dementia precox from bipolar or manic depressive insanity. And so I really appreciated and the comments that you had to make. Thank you so much.
Thank you. And I wanted to add to that even with antipsychotics, which we routinely use, even they have anti-inflammatory properties. So could they be contributing to the improvement in symptoms partially through their anti-inflammatory profile? That could also be true. So we don't know. Unfortunately, there is so much we don't know about that.
I'm sure that we could keep going because this is such a timely and important topic and discussion, but unfortunately, we're going to have to thank you and say good night. But really, it was really wonderful.
Thank you.
And congratulations on a tremendous study and a very good presentation.
Thank you so much. It was a pleasure.
Yes, and I'd like to thank our presenters and my CME committee colleagues and everyone attending. And we want to keep the poster competition winner train going next month, October 8th. A diagnostic challenge will be presented. Very interesting case. Hope to see you then. Keep your eye on the WPS website. Have a good podcast coming up soon, and hope to see you again very soon. Thanks, everybody. Good night.